So everybody, I'm Sundus Maqsood. I'm one of the SG4s in ophthalmology, and
I'm Sim. I think you know us both quite well. And we know you quite well too.
So I asked him to start. She has made a little presentation, and then we'll take answers.
Is the screen okay? Should I bring it
That's
forward
good.
back? That's good. So just wanted to go over some basics. This isn't exactly directed at all of you. It's more sort of for the nursing staff in our department, but that session got cancelled, so because you know more than some people do. So if anything is really simple for you, then just ignore it. But just some basics. I just wanted to make sure everybody was aware about. So just we're going to go through basic anatomy again, basic history taking, and basic examination. Then we'll do questions and any practice on this if you want. So anatomy. Anatomy is very important when we're often on the phone taking referrals before we see the patient, and we need to know what is it. Is it red? Is it red all over? Is it only red in one section? You know, it's not, you wouldn't believe what we hear sometimes on the phone. So whenever we get dodgy referrals, I just accept it because the other person has no idea what they're looking at, and it's never MIU. It's always dodgy opticians.
And you would never know that even just a small red eye can have a very serious pathology in it.
Mm.
So, of course, not all red eyes, but if you can get a good history on the phone, because that's what we usually do when we are, especially on following weekend as well, that's very important. So never underestimate it.
So yeah, ophthalmology is mainly history and examination. Boom, you've got your diagnosis. Different to general medicine, I guess. Not always that way. Okay, so basic things, just so that we are clear. What the arrow, so the white bit is the sclera, and it's the conjunctiva that sits over it. I know you all know this, but I just go over it again. The brown bit, which is also blue sometimes, that's the iris. I've had phone calls with, oh, we've dilated the fundus and the iris looks red. So this is why I'm going over this. And I'm like, what? We've dilated the fundus and the iris looks red. Okay, yeah, I'll see the patient. The arrow is pointing to the pupil, which can be small, can be dilated, can be irregular sometimes, depending if they've got inflammation. And then, what's the next? Oh yeah, that's about it. This is a slit lamp, as you all know. The markers on the side just help you with alignment of the patient. So ideally it should be matching the end of the eyelid, yeah?
Mm-hmm.
And that just gives you the best.
You happy with using, I'm sure, I know that you guys are really good in using slit lamps, but you happy with focusing on whatever structures you want to see, especially in tear segment, because we do not expect you to see the posterior segment. Are you?
No. I'd like to, yeah, it'd be
Yeah,
good to spend some time.
so,
It'd be good to spend some time, yeah,
Yeah.
just to demonstrate.
I'd be happy if you want to practice on us.
Thank you.
It's
It's
fine.
measuring stuff as well, because I've forgotten how to measure corneal ulcers. I did know how to do it, and I finished measuring
Yeah,
Yes.
and also the depths of foreign bodies.
yeah,
Right.
fine. Yeah, we can go over that.
Yeah.
And sometimes when you feel that focus isn't quite right, it's not necessarily due to the front and back. Sometimes if you haven't got the right interpupillary distance, then you're either just looking with one eye, you're not looking with both eyes. So it's
You need to
important
look through both eyes.
Exactly.
Make sure that you close one eye and see whether you're seeing clearly one in each eye, and then when you open both eyes together, because if you're squinting and if you're closing one eye, you wouldn't get the depth perception. So depth perception is the ability of the two eyes working together, fusing two images as a one image, and the slight disparity between the two images give you the depth perception. So if you're not using one of your eye, you won't get the depth perception.
Yeah, and you'll feel that your eyes strain because you're like, you're having to, focus through one eye rather than both. You should be relaxed. Just open your eyes and you should be able to see, with both eyes.
Another
open.
thing is, well, I've often come here and noticed that there's a number here, which is mainly for anybody who's got a refractive error, like yourself. You're wearing glasses. Some people would keep wearing their glasses and use this 0 setting and examine the patient, but some people prefer to take the glasses off and put the prescription here if they know rough prescription. I would recommend not touching it, keeping it at 0, because often if you are not in practice, you would come and start seeing patients when it's on, for example, 5 + 5 or something, first if somebody has changed it. Because often I've come here and I found that it has been dialed a random number. So it has to be on 0 so that your eyes are not straining and not accommodating. That's also one of the reasons why you are not able to focus very well.
That's true, yeah, very true. So this is just a useful mnemonic which I learned: afro, acuity, fields and fundus, reflexes, and then ocular movements. You don't have to do all of them in all patients because we don't, but it just depends on what the symptoms are, what the patient is presenting with. So simple things is quite important to just do them well. Acuity, we do it one eye at a time and ideally with their distance glasses on. So when they sit here, looking through the reflection, that's 6 meters. If they can't see the biggest letter at 6 meters, then you bring them closer and closer until, if they're like at 1 meter and they still can't see it, then you go to, can you count my fingers? Counting fingers is better than hand movements, and then it's perception of light or no perception of light, then it's a completely blind eye. So it's quite important to, I try and encourage them as much. So even if they're only getting sort of 3 out of 4, I really try and push them, because sometimes with just a bit more encouragement, they can actually read the whole thing or get to the line below, especially children. You get referrals, oh, the vision 624, they bumped their head yesterday, and they come here and they're actually 6'9" because they just want a bit of attention, I think. So they're like, no, I can't see anything. So acuity is just really important to do the basic things.
Make sure that if they wear distance glasses, they are wearing their prescription when you are checking the vision. Because there is no point of checking the vision when they are not wearing their distance glasses. You're not counteracting it. It's not reliable. So make sure you ask. This is the first question you should be asking: whether you wear glasses all the time or for distance. Please wear them, and then you would ask them to sit here, as mentioned before, that this is a 6 meter distance. If they are not able to see the top letter, then you ask the patient to stand up and come in the middle of the mirror and here and ask the same question. If the patient can't still see anything, you can't really go. If you want, you can go a little bit further, but that would not maybe add anything to your examination. What you would do then, you ask the patient to turn around and directly see. So that distance is less. So you ask the patient to see if they can see the top letter, and of course do the pinhole as well. That would also give you a point if, for just in case if they've forgotten their glasses at home. That is one section. Another, that if there is a refractive error which hasn't been corrected, that their vision would improve with the use of pinhole. Everybody is aware of use of pinhole?
Yes. Yeah.
So the big one and then pinhole after that.
So even at here, they are not able to read the top line on the chart. Then you ask them to sit back, and then you would do the finger counting at 1 meter or hand movements at 1 meter. If the patient are not able to see those either as well, then you would show some light and ask them whether they can appreciate a light in that eye. And if they can, then you would say the vision would be quantified as perception of light. Okay.
Have we got another one of those pinholes for the other room?
Which room?
For the other eye room?
Oh, I don't know.
Because when you guys are in here,
You use that.
we use the other room. So
Right.
I feel like I've seen 2 in here before, but I don't
Have
know
a
if there's
look.
another
If they
one.
are not there, ask the outpatients.
Okay.
They might be able to provide you one.
I thought we had 2 there before.
I thought
Yeah,
I think one might be in the drawer.
We had 2.
There might. I feel like I've seen 2 in there
Okay.
before, so one might be in the drawer. Otherwise, just clinic will be able to give you one. So yeah, just vision pinhole. We've got that. And then fields, just to keep it simple, you can just break it down into quadrants, 1 eye at a time. So you're matching the patient. So for example, the both of us, if I'm testing your right eye, then you cover your left eye with your left hand, and I'm just going to mirror you basically. Yeah, and then you can either say, are my fingers wiggling or not, or how many fingers have I got, and just keep it simple, do the 4 quadrants if you're suspecting any field loss.
This is quite important if you're suspecting retinal detachment.
Mm.
If there is a retinal detachment and they have a significant retinal detachment, will give them a field defect, which you can pick up on just confrontation field test.
Yeah, so like with the flashes and floaters patients, before, because we will dilate and have a look at the fundus, but if you were worried
If
that there was
if
anything
they're complaining of a shadow,
Mm.
then do a visual field confrontation, and that can confirm that they can't really see through that shadow.
field defects generally, if they're horizontal, then it's retinal coming from the eye, and if they're vertical, then it's likely brain, so strokes, hemianobias, that kind of stuff. So anything respecting the horizontal midline is usually from the eye, so detachments, vein occlusions, artery occlusions, things like that.
So double vision. So where they see two. So if you've got two people side by side.
Yeah. So you want to find out if it's horizontal or vertical, because they can have double vision, top and bottom as well. And is it in one eye or is it with both eyes? Because that's very important as well. If it's just in one eye, then it's probably a refractive issue, something to do with the cornea or the anterior segment. But if it's with both eyes, then it's likely to be neurological. So yeah, a lot of people, and when they say, oh, I've got double, what do you mean? Oh, it's just a little bit fuzzy, there's like a halo or something. So it's not, so again, I try and find out, do you actually see two faces, two pens, or is it just one and like a bit of a shadow? So, just to be, is it distinct and is it bilateral or unilateral? So sometimes even over the phone, when the patients ring up the eye clinic and if they say, oh, I've got double vision, and if they haven't checked whether it's one or both eyes, just on the phone I say, well, cover one eye now and tell me what you see. Is it still double or not? So useful to know. Horizontal retinal and vertical neurological. What's next? Oh yeah, just light reflexes. So everybody knows how to do direct, consequential light reflexes. RAPDs, if they're very obvious, then they will be easy to pick up, but sometimes they're a bit subtle, but don't worry, because even I struggle with that.
Everybody's clear on RAPD?
We can go over it, So, shine the light in that eye, that's a direct reflex, that constricts as well.
Yep.
Shine in that, direct there, consensual in there, will constrict. And this is just to show normal, this is all normal, right? Actually see what I'm doing. Is that RAPD on the slide?
Yes.
Yes,
It's RAPD.
RAPD.
Okay, so rather than explaining it
Should we
here,
practice it?
yes, I'll tell
practice,
you how we do it. So sorry, I'm just gonna take this there. Okay. So like in her case,
We did one of the switches.
and you don't get good results from it. So it's best you have a good light source. If you've got a good torch, then that's fine. But if not, then you can use this. What you would do in order to look for a relative efferent pupillary defect, for example, Sim has come with a vision loss in the left eye, for example, and I want to make sure that there is no RAPD in that eye. So do you know what does RAPD stand for? What does it tell you? Yeah, but what does it tell you about the eye function?
Affecting the optic nerve.
Yes, it tells you the function of the optic nerve. It's very, very essential in 2 or 3 cases which you would be seeing in A&E. One is the orbital floor fracture. If they come with a completely closed eye and floor fracture, swelling all over, and although the scan can be normal or abnormal, plus minus, an important thing which I would like you to do is to check RAPD in that situation, because the only thing we want to rule out is that there is no compartment syndrome. Compartment syndrome is that the soft tissue swelling that causes the compression on the nerve and can cause damage, irreversible damage. That's the situation when we would like to see such patients urgently, because we would do an emergency procedure involving cutting the lid on this corner of the eye to release the pressure. So if I'm looking for the relative efferent pupillary defect in the left eye, I would first of all, for any patient, checks the normal reflex and check whether you can see, although she's got good dark eyes, but she's got good direct and consensual reflexes. And when I've decided that I'm getting good response with both direct and consensual reflex, I would then start to swing the light between the 2 eyes, like that. So, and each time when I'm looking at the light, I'm looking at the first response of the pupil. Usually and normally, it is that the pupil constricts. But when you're swinging the lights very quickly between the eye, that you're not giving the eye time to redilate once the light source is taken away. So you would notice a very quick constriction, and then pupil will dilate when you're doing that. In relative efferent pupillary defect, after doing the swinging few times, the affected eye, the first reaction of the pupil to the light would be dilation instead of constriction. That's a relative efferent pupillary defect. Of course, she doesn't have a relative efferent pupillary defect, but I'm glad that you have that's what you would look for, and that is also useful in patients often patients present with optic neuritis, like MS patients. It's usually their presentation, so to A&E or out of hours. Or often they are known MS patients and who have been complaining of, we've got some reduced vision and we've got pain on eye movements, which is very typical of optic neuritis. They can have relative efferent pupillary defect because the nerve is affected in that. So these are the two main scenarios where you would look for relative efferent pupillary defect, and it will of course change your management, and it will change the way you would contact us and we should be coming here or not.
Good.
Everybody's happy about relative efferent pupillary defect?
Can it also be caused? I just think the first time I'd ever heard about it was a few years ago. One of your colleagues had been called out to AIDS, a child complaining of loss of vision.
Yes.
And he had positive graphics. And
Okay.
he had a clot.
Clot
In the artery. Yeah, something affecting the blood flow.
right. So
Veins.
Yeah.
you can have
You said it was very rare.
if it is central retinal artery occlusion, you would develop disc swelling and you would develop relative efferent pupillary defect. It is present, and it's a sign of poor prognosis because the vision loss is a bit irreversible if you develop a relative efferent pupillary defect. You would also develop a relevant efferent pupillary defect when you would have advanced glaucoma. So advanced glaucoma would have all the nerve fiber layer has been wiped off due to high pressure in the eye for a long period of time, and the nerve just becomes dead, and you would have a RAPD in that situation as well.
Okay.
All right.
And they're not likely to present at urgent care, is it?
No, this is usually long-standing. Urgent situation would be in orbital floor fracture, compartment syndrome that can compress the optic nerve, any form of facial trauma, but or optic neuritis would have. Not always they have it, but they can have it in acute setting.
And it just depends on, I guess, ultimately what the cause of the optic nerve dysfunction is to have resulted in the RAPD. Some patients can have pretty good vision still with an RAPD and others don't. I've seen like 6/12 vision with an RAPD because it just depends on the cause of the symptoms. I have a few slides on common conditions which you've all seen before, so I'll go through that after. But yeah, history in terms of red flags. Do they wear contact lenses? If it's a red eye, we always ask, do they wear contact lenses? And have they had recent surgery? Not necessarily lid stuff, but just any surgery to the eye. Whether it was glaucoma surgery, injections to the eye, cataract surgery, anything, any form of surgery, just because we're thinking of things like endophthalmitis as a cause of their red eye or their painful eye. And
Do
then
you know
trauma.
what endophthalmitis is?
No. So what is it?
So endophthalmitis is an inflammation of intraocular contents.
Anophthalmitis.
Endophthalmitis.
So it's END,
Yeah.
OPHTHAL mitis.
It's a very rare complication of cataract surgery,
Okay.
1 in 1,000, and even rare complication after the injections. So any intraocular surgery, retinal detachment repair, glaucoma surgery, normal cataracts and injections, they can develop this rare. It's very rare, but we have seen it, and it can happen. And usually these patients who are, they would give you a history of a recent operation and blurred, very bad vision with severe pain in the eye. And you can see this white hypopion in the eye. We can go through what hypopion is, but usually that's the very classical features of endophthalmitis. And the most important thing is that they would have a history of a recent surgery. Although you can very rarely have endogenous endophthalmitis, which is not related to the surgery and which is related to patient's own immune system and their own body reaction, but that is extremely rare. Most of the patients you would come across are, we had cataract surgery 2 weeks ago, 1 week ago, we had injection 3 days ago, eyes is very, very sore, it's red, vision is down. It is endophthalmitis proven otherwise. And that needs to be seen as soon as urgently as well.
So yeah, that's very relevant. And contact lenses, injury, and also do they have any other eye problems? Are they a glaucoma patient as well? Do they have macular degeneration? If they have macular degeneration in one eye, it's very likely that they could develop it in another eye as well. So ocular history, past ocular history is relevant. And then just some pictures and some common cases. So foreign bodies, you've all seen them and you've all had a stab at removing them. Any questions about?
You were talking about the depth.
And size.
Yeah.
How do you measure how big the object is?
Not object, is the ulcer.
The ulcer, yes.
So related to the depth. Because it's a slit lamp, so there is a reason why it's called a slit lamp, because you can create a slit beam and show the light from the side. Majority of the time, you guys would be using the slit from it's not the slit from the side, it's basically viewing which is from the side. Slit is coming from the lamp here. So you would try to aim a beam from the side and try to look through the layers of the cornea. It comes with a lot of practice. Please don't get discouraged if you're not able to see it. You need to see it a lot. You need to do it all the time in order to get better at it. Just like us.
Just knowing that there is something there that shouldn't be there is important in terms of how deep the ulcer is, even like between ophthalmologists.
Yes, it doesn't matter that we don't. I mean, of course, there are rarely you would see corneal perforations, and you should be able to pick if you're thinking about those, but they are usually not that common. If it's a normal ulcer or a normal metalliform body, it doesn't really matter that how deep it is, as long as you know how deep you can go to take it out. If you can't, of course, you can always refer those patients to us. So foreign body, for foreign body, I would say that if you especially are removing foreign body for a few days history, they would have a rust ring around them, and they are often quite difficult to take out in first attempt. So in those situations, it's best to take the foreign body out, and if for the remnant rust ring, you give the patient ointment, chloramphenicol ointment, not the drops, 3-4 times a day, and ask them, and they would be seen in next 2 or 3 days, because the ointment loosens the surface layers and it helps to dig out more easily at the next attempt. So that's what we would like you to do. But I think general foreign bodies, if you are happy that you've completely removed it, you don't have to really put them in our cabinet, because you usually don't see them.
And if you think that it's penetrating through and through, like the case we had last week, I don't know if you remember. Yeah. Then don't take it out, because the child, do you remember? Don't take it out, because we wouldn't take it out either, and then they would have to go to theatre to have it taken out. Even though we didn't have to go inside the eye, my consultant just took it out from the top, but we were in theatre. If it had broken and it was floating around inside, then you have the ability to do that. But if it's through and through, just leave it.
Was that high velocity?
No, it was a child. He was playing like sticks. I don't know, hitting sticks with his brother, and they were like in Italy or something. It happened the day before, and a little piece of it was like a thorn that just went into his eye. And
it kind of went in horizontally. So when you first looked, you couldn't. When I first looked here, I couldn't see it. Went to get it out, thinking it was a surface, and then literally saw a thorn through the anterior chamber moving, and kind of went, "Oh, I'm not doing it anymore."
You can see it. It was through the entire cornea, poking through the other side. So don't take it out. And then lid eversion. Everybody happy with lid eversion? Different ways of doing it.
What do you find? Yeah, because I've tried, but is there a more effective way?
When would you do a lid eversion?
For a
Would you do it on every patient?
No.
No.
Foreign body sensation.
Foreign body
Foreign body
sensation.
Okay.
Yeah.
And you would do in chemical injuries.
Mm.
Very, very important.
Okay.
That's the own, I think, foreign body sensation is one thing, usually, and how many times you have actually found a foreign body?
Quite a few.
One.
Really?
Just one.
Yeah.
One is
Yeah.
good.
Yeah.
In the last,
Hiding in
in the
there.
last
Yeah.
week I've found
If you
it.
clean it, you know,
Oh,
if you clean
If
it.
you, if you take the front body out from under the eyelid and there's
Yes.
no abrasion on the
Yes.
surface of the eye,
Yes.
would you give them tryptophan collar?
I would not actually.
No,
If
that's
you
fine.
if you are sure that there is no abrasion, then you wouldn't, because you
Yeah.
would only give it. It's just to prevent infection. It's not.
Yeah.
We're not treating anything at there and then. But in most important emergency setting, which you would be, you must do aversion, is when you are dealing with chemical injury. When you are irrigating, you need to do aversion, and you make sure that the irrigating fluid goes in the fornix. Fornix is the edges of the corners of the eye. We need to make sure, because often, like chemical injuries with cement and plasters, they have small elements that can go and stay there, and they can slowly keep releasing the chemicals even if you have irrigated the eye.
But we use the Morgan lens.
Yes.
Would
Yeah.
that, so we
That should
still, we
go-
wouldn't still have to do an aversion if we've got Morgan lenses.
After
It
you
doesn't
do
go
the Morgan
well.
lens, I would, because the
That's
Morgan
the
lens
special
helps
stuff.
to push the fluid through under the lids.
Yes.
But after you've irrigated and
After
checked
you've
the
irrigated
pH,
and you've
good to
checked it,
just
give yourself
divert.
some time, good few minutes, before you check the pH again, because that wouldn't be the true pH reading if you do it immediately, because it would be diluted.
Yep.
You've freshly irrigated the eye and you've just put the litmus paper in, and it will give you a false reading. So give at least 15 minutes and then check with the litmus paper again. But when you are examining the patient again on the slit lamp, try to look for, revert the lid and look for any remnant materials. Usually the material I'm talking about is not the small tiny bits. I'm talking about big bits which are stuck to the surface of the conjunctiva, and they need proper they need proper removal. Like foreign body, you would use cotton bud and you would remove them from the conjunctiva. So that is the time when you would do the lid aversion.
abrasion. So abrasions are breaks in the epithelium of the cornea, and it tends to be, they're clear, they're sort of see-through, they're not white or opaque, and they will stain like that. And that can happen from scratches, foreign bodies and things. Not often serious, but can be very, very painful. We don't give them proxy to go home with, but give them as much proxy whilst they're here so that they're comfortable, and just cover them with antibiotics really from phenol ointment.
And if it's big and giving them a lot of pain, it's worth giving them the cycloplegia, like cyclopentalate. That will make the pupil big for few days, but it will relieve any spasm. But the pain is mainly because the ciliary muscle goes into spasm when you're exposed to light. So when you cycloplege the patient, when you use the cyclopentalate to dilate the pupil, then there is no chance for the ciliary muscle to go short and long with contraction. So you just relieve the spasm, and they get really symptomatically they get better by giving.
How often do they do that?
Usually it's twice to 3 times a day for a few days. And tell them that it will blur the vision, but it will improve the pain.
Do we send them home with a patch over their eye? Is that or not?
Not really,
No.
unless it's a very big abrasion, unless it's covering the whole of the cornea.
Okay.
I mean, if it's like very late at night, and if I've been asked to about a patient who's got like a really big abrasion, I would tell them that put loads of chloramphenicol ointment and pat the eye and see the patient next day or something. So, in rare instances, but there is no benefit of patting the eye
Okay.
with any form of corneal abrasion.
Okay.
And then the
What's
difference
that?
this is nasty. And you can see how it's different. It's an opacity, so it's not clear, not an abrasion, it's an actual ulcer. Commonly they are contact lens patients or patients who have had foreign bodies go into their eye. This will also stain with fluorescein. So there is also an epithelial defect, but there's a lot of pus, white cells, abscess there. So depending, what we normally do is we measure it. Again, we can come to that in a minute. If it's generally less than 1 millimeter, we don't take samples. We just start treating it, and it's usually levofloxacin, so we don't use chloramphenicol for these things. But if it's larger than 1 millimeter, then we want to scrape and take the results, send the samples, and again, treatment is the same. It's just whether we decide to scrape them or not. So it's just, you know, to be aware about what the difference is between an ulcer and an abrasion. Anything else to add about this?
And that eye is very
Yeah.
projected.
Yes.
Is that a common thing with a corneal ulcer, or
Yeah,
can
yes,
it be?
yeah,
It
yeah.
is.
Even with abrasions, they can be quite red just because it's so tender. It's like a really bad scratch on the surface of the eye. So it can also be very, very red with abrasions. The vision can be quite reduced with abrasions, especially if it's in the center as well. So yeah, it's not uncommon to have like 624 maybe vision, especially if it's right in the middle. But you know, once epithelium heals, vision will get better.
Is that just in contact lens wearers?
Yeah.
No, also
Do
can
you-
happen in anybody,
Anyone.
but contact lens patients are more prone to develop ulcer, and they are more prone to develop nasty infections compared to other, because there are certain bugs which are more the contact lens wearers are more susceptible to, partly because of the fact that they are introducing a foreign body in their eye on daily basis, and partly because in doing so they can do a tiny scratch on the cornea and they wouldn't know it. So that's the entry point for normal bacteria, which would not give you an ulcer in normal circumstances, to produce an infection there. So they are basically more exposed to pathogens compared to people who do not wear contact lenses. And of course, with the contact lens solution and cleaning and hygiene, certain kind of bugs are very, very common in contact lens wearers. One of them is acanthamoeba, which is not really a bacteria, it's a protozoa, and it has a very poor prognosis if it's not picked up early and not treated properly. So that's why we jump usually quite a bit when we listen to the fact that they are contact lens wearers as well.
Yeah, exactly. And then just